Again, warm welcome from the Department of Surgical Gastroenterology, Yashoda Hospitals. And it's an absolute delight to present in front of people who grew up idolizing Dr. Pallimil sir, Haribhakti sir, and teachers like Pratap Reddy sir and Birappa sir. Luckily, I am not talking about surgery in front of them, I'm talking about ICG. So, gastric cancer has been a difficult topic to discuss. And surgery has always been the cornerstone in the management of gastric cancer. And D1 gastrectomy has been the standard of care for decades. And fortunately, over a period of time, technology evolved, technique evolved, and we have moved to function-preserving gastrectomies for early gastric carcinomas, as well as multivisceral resections for advanced carcinomas. We have come to this stage because of multiple technologies. One of them is ICG. ICG, I'll not go into the details of it. It's a dye that binds to plasma proteins and emits light at 820 nanometers. The greatest advantage was when it was adapted for liver surgery and later on adapted to GI oncology since 20 years. What's so special about ICG? It deposits longer in lymphatics and stays in the lymph nodes even when given preoperatively a day before. The arteries are better visualized and it has no ionizing radiation. It has absolutely very low allergic reactions, up to 1 in 10,000 according to the manufacturer, and almost invisible to the human eye. This gives it greatest advantage in dissection because it doesn't alter the surgical field, unlike a dye which smudges the field and makes a dissection difficult, or when you are using a radioactive colloid, you require a gamma probe which is expensive and difficult to manage, or the radio clips, or the intraoperative ultrasound. So ICG gives the advantage of being simple, cheaper, and easily available. So what are the possible situations where ICG can be used? In early gastric carcinoma, which is considered as the most common carcinoma in Western Asia and 20% of Western countries, often subtotal gastrectomy or total gastrectomy is considered a regular surgery, and over a period of time we realized it's unnecessary and it's overkill, considering that there is only 10 to 15% of lymph node metastasis in these cases. So as my earlier speakers have told, that functional gastrectomy with sentinel node surgery is accepted as a better alternative now. The biggest challenge comes in identifying the primary in early gastric cancer, because it's such a small lesion that is difficult to palpate in laparoscopy. More so when it is in the mid-body, it is difficult to identify the tumor, and even more difficult when you're doing robotic surgery, the palpation is absolutely impossible. So incorporation of NIR cameras in regular laparoscopy and Firefly and robotic have made our job easy. Identifying the primary tumor has become the easiest job now. And once it is diagnosed, when a primary is detected, then the next comes the sentinel node surgery. At least till 2022, it is not considered as a standard of care. Even now, it is not considered a standard of care. But nevertheless, we are attempting to learn new things. Let's learn this. The sentinel node navigation surgery is initially proposed by Kitagawa and Takeuchi in 2013. Since then, it has been adopted and modified continuously. But the standard approach is when the tumor is less than 4 centimeters in some studies, 3 centimeters in studies, and it is T1 and not extending beyond mucosa. In this, the dual tracers are given around the tumor in 4 quadrants, and the lymph node basins are collected and checked for frozen. And if frozen turns positive, we'll end up doing distal gastrectomy or total gastrectomy based on the location. Or if it is only localized, we end up doing only partial wedge resection or even endoscopic resection.